Good. All right. Good morning, folks, and welcome to Friday Chalk Talk. My name is Martin. I'm your moderator for today. And this morning, we have a very important and pragmatic topic. It's the physical exam at the end of life. Our guest today is the talented Dr. Jen Turpin. Jen is currently a hospice and palliative medicine fellow at the Medical College of Wisconsin, and she completed her family medicine residency at Deaconess Family Medicine in Evansville, Indiana. And one fun fact about Jen is that she is a fellow Harry Potter fan, as am I. And so, Jen, can you tell us, by putting you on the spot, what house the Sorting Hat would put you into?
So being a true nerd, I've taken many quizzes, and it took me a long time to accept that all of the quizzes had to be right. I kept getting placed in Slytherin, and I was like, oh no. But I think it's because I'm very driven and ambitious, which those can be good traits. You just have to temper them with empathy. And so
I like that. You're in good company. I am also a Slytherin. So
yes.
yeah. So today's format is two parts. Followed by, we're going to have a little lecture, and followed by some time at the end for some questions. And so, Jen, we're lucky to have you today, and I hand the mic over to you.
Thank you guys so much for inviting me to come talk. This is a topic that I'm pretty passionate about, and I like this to be, I really like the humanities. Full disclosure, I was a psych major in undergrad and went to a liberal arts school. And so I like to incorporate a lot of things into my talks. And so you'll see a lot of different arts in here, artworks. And so one of the first pieces is the death of General Washington or President Washington. And you can see that he's surrounded by family. It looks like he's probably surrounded by physicians who are pondering his death and trying to care for him. And in the 60s, 70s, society kind of started to ask what constituted a good death and what that might look like. And so I think that's always important in our field to consider what different opinions there might be on what a good death would entail. So part of my objectives today is to discuss the importance of doing a physical exam at the end of life for your patients who are in facilities, and to identify the components of a useful physical exam, and to interpret the physical exam findings into the meaningful information for the patient and family. We're also going to kind of talk a little bit about the history of physical exam as well. And so one of the first individuals who really started physical exam skills was a physician from Austria, whose parents were an innkeeper and a musician, who really thought that percussion might be able to help give him some clues as to what might be going on with a patient. He was pretty much largely ignored, even though he published his studies in the Inventum Novum. And it wasn't until about 40 years later when a French physician really popularized the percussion. Later, physical exam was again revolutionized by the development of the stethoscope by another French physician, Dr. Laennec, who also had a hobby of carving wooden flutes, and he played the flute, and that kind of led to his development of the stethoscope. I debated whether or not to put Dr. Osler in, given a lot of the recent controversy over some of statements that he's made, but he did bring back into medical education the importance of clinical exam skills, and so I do think that we should respect him for that, and maybe just try to accept that all humans are flawed and that he was a flawed human as well. And then one that I think is currently starting to revolutionize a little bit more is ultrasound. In my medical school, they incorporated that very heavily into our anatomy curriculum. And with the advent of point of care focused ultrasound, where you can like attach it to your phone, I do think that is changing what we consider physical exam, because in the past you would consider ultrasound to be more of like an imaging finding that's can be diagnostic, but not necessarily like a hands-on physical exam skill, but it can be. So why did I call this a lost art? And it's not just me. There's a lot of discussion, and there have been for years, about the lack of new physicians' abilities to really harness their exam skills. And so being an osteopathic physician, we spent a lot of time really honing our trusting our hands and what we would feel and what we'd say, see, and within the patients. And so there's a lot of different theories of why this could happen. Is it because of teaching methods? Is it because we're doing like a complete head to toe, or are we doing a systems based? Should you have to do like a physical exam, or do you rely on your history to really guide that and just really hone in on that? And then is it because we're not doing a lot of teaching at the bedside in front of the patient, and we're relying more on computers and doing table rounds and looking at that? And another option is, who are the new physicians learning from? Are the students learning from interns? Are they learning from residents? Or are they learning from the attendings? And most of the time, the medical students are spending a large portion of their time with the intern, who just sometimes even just like 2 months ago was a medical student themselves, and they're in charge of teaching somebody new. And then there's also the perceived subjective nature of the physical exam, because different people have different abilities. Technology, are we relying more on lab testing to really help us make our diagnosis? And the increased availability with CT and MRI scans and things being cheaper, and like I mentioned, the point of care ultrasound. And then is it also due to a change in workload? There's been a lot of talk about residents unionizing, and some of the older physicians are like, we can't have that, because back in my day, we worked for 120 hours or more a week, and that was the only way to do it. And then there was an interesting study that we're going to talk about a little bit that came out of Turkey. And it just looked at, was COVID-19 the final nail in the coffin for physical exam findings? And so it was a survey-based study for mainly medicine residents, but there were others included as well. And as you can tell, that like about 16% weren't performing a head and neck previously. And it slightly increased with COVID. And then again, they were doing it beforehand, and it actually increased for their examination. And then they didn't change their practice at all for some. And so most importantly, I think with COVID-19, with the respiratory problems that comes on, you can see that about 12% weren't performing respiratory exams in general beforehand. There was an increase in respiratory exams showing that they were taking their history and looking forward and using those methods. And then about 49% who had been examining before in general, but had decreased to about 35% if they had COVID-19, which is a little interesting. So the authors looked at what could be contributing to this. And one of the big things that I'd like to draw your attention to was that they would attribute it to avoiding physical exam to limit their exposure to COVID-19 about 7.5 times more often than not. And so, and it wasn't really the lab or diagnostic tools that we had. So that's just a little side art about like just physical exam in general. This was a painting that hung in my medical school called The Healing Touch by a artist in 2009 that looks at Andrew Taylor still examining a family. And I think it's important because Dr. Still lost his own wife and child very early on to illnesses. And so he thought there had to be a different way in like the 1870s of looking at medicine, which was prior to Dr. Osler talking about clinical exam skills. And I think it's important to look at this from a palliative standpoint too, as because it's not just about the physician and the patient, it's about the patient and the family who's looking on and the siblings, and even the dog is included in the family. And so this is just something that I would walk by every day on my way to class that just really kind of stuck with me that I wanted to share. So why is physical exam important at end of life? It emphasizes non-abandonment. A lot of families and patients feel like if they've chosen a comfort route and that physicians have just thrown up their hands and they don't have anything else. And so continuing to do those physical exam reassures them. It also allows you to assess symptoms, which we'll talk a little bit more about. It can provide you with prognostic data, which we'll also talk about further. And it can help you with your decision making about how to treat the symptoms, and then also what kind of advice you give to the family as well. So for pain, things that we're looking for that everybody knows about is grimacing, brow furrowing, is the patient moaning? Are they restless or tense? Do they have tachycardia? Are they breathing more rapidly? Do they have altered breathing patterns? Are they restless? And then I really liked this quote by Dr. Riley. Most of these signs were noticed by Hippocrates, and strangely, there have been very few signs added since his time of an occurrence that has been observed by millions of people an innumerable number of times. I believe that most of us think that we recognize the onset of death instinctively, but this is not so. It must be as a result of previous observations, and it is my endeavor to bring together the facts on which we make this judgment. So that was just a really powerful quote that I think really speaks to the importance of physical exam at the end of life. So some of the early signs that death is coming on, these can occur weeks beforehand. Their functional status is going to decline. They might start having problems with swallowing, whether this is from being weaker or if they're having perfusion problems with the brain, with the neurological complexes, and they're likely going to have decreased oral intake as well. They just won't feel as hungry. And then signs that death is imminent in the next 3 days is the loss of the radial pulse, mandibular movement during breathing, anaria, the Shaney-Stokes breathing, and then the death rattle. I don't think that we'll have time to really look at the video of the Shaney-Stokes breathing pattern, but just for completeness sake, it changes and there can be different ways of looking at it. And I can share these slides too, so that way people can look at the videos if they want. And then the respiration with mandibular movement. There was a study that looked at the onset of that, and most patients who started displaying signs of respiration with mandibular movement died within 4 hours or less, 4 to 12 really, to look at more than 50%. So, and I do want to just briefly, this is a physician demonstrating kind of what it looks like. I've heard it described as guppy breathing with how fishes breathe. So the death rattle, Marty, you did an excellent chalk talk on spending time about the death rattle that I appreciate. This study that I'm referencing here is very controversial about whether or not we should be prophylactically treating this, because it doesn't seem to be bothering the patient and it seems to be disturbing the family members more. I thought it was interesting that they were able to name it the silence study. But it was a double-blind randomized control trial with hospice patients, and only 13% of those on the prophylactic scopolamine experienced the hypersecretions compared to 21% of those who were given a placebo prophylactically. And there was no clear evidence of increased rates of adverse events. So looking at some of their data for it, you can see that when the death rattle occurs less or closer to the time of death in the scopolamine, whereas it is earlier in the placebo. So late signs when there's less than 72 hours, most of these are neurological signs. So non-reactive pupils, decreased response to verbal stimuli and visual stimuli, the inability to close the eyelids, the drooping of the nasolabial fold is a big one, hyperextension of the neck, grunting of the vocal cords, and then some will have an upper GI bleed, which is really the only non-neurological sign. I think it's also important to note here that a lot of times we tell families that hearing may be the last thing to go, but I don't know that I was really able to find much research to support that. However, there are some studies, and again, these are probably controversial, looking at people who've had near-death experiences where they've attached EEGs and then ask the patients what they remember. And sometimes they're able to provide in great detail what was said and what was around them. So that could support, but that doesn't necessarily correlate to everyone, as it's just a few cases. So looking at the timing, like I said, most of these are 72 hours or less, or they're going to be spending more time sleeping. The grunting of the vocal cords and the inability to close eyes are most likely within the last day or day and a half. And the drooping of nasolabial fold is closer to 2.5, although it can range a little bit from 1.5 to 3. And this is just another way of looking at the data. No lecture about physical exam at the end of life would be complete without talking about the Kennedy terminal ulcer, which was named by a nurse practitioner in Fort Wayne, Indiana. And there, again, this is controversial. There was a physician from Indianapolis who says that this is just poor repositioning. However, with all of the nurses that I've spoken to who have been in hospice care for so long, most of the time these patients who develop these, they see it more as they've been repositioning and the skin's fine at like 8 o'clock, and then by 3 o'clock the skin looks like this, and it's just a sudden change. Some people consider it to be like a stroke of the skin, where it's the sudden infarct, because the skin is the largest organ system. And when we're starting to have problems with our blood supply, it could cause easier pressure sores to develop. So how do we communicate this to our patients and their families? And then this is a woodblock printing by Hans Holbein, who's most known for his ambassadors painting, but also did several paintings of King Henry VIII. And this was like a 34 series paintings that he did, looking at how death comes for everyone. And this one is called The Duchess. So we talked about the prognosis of certain physical exam findings. So it's always important to ask the family if they want this kind of information before you share your findings. And some families want all of the information and they want to know how you're doing that. So it's because sometimes they may want to be looking for those signs too if they notice a status change. And other families just don't. And then it's also important to normalize the signs and symptoms, especially with the death rattle. That is one of the most important things that you can do is talking about it before it happens. So that way they're not as stressed about it. And then you can address any concerns that they have and provide social and spiritual support. I think going back to the hearing piece, you can talk to the family and share with them to share their memories of their loved ones, because that could be encouraging and keep the patient calm as well. So Dr. Murthy, who's one of the Surgeon Generals, recently said, "We forget some of the oldest medicines we have are love and compassion, and they can be deployed by everyone." And so that was my talk. I have a bunch of references, and we can open it up for discussion.
Thanks, Jen.
Yeah.
We will open it up for questions, and while I give people a moment to think about what they want to ask you or comment on, I wanted to share one of my struggles that I have with this. We want to be evidence-based, but most of the literature on this is in oncology.
Mhm.
So a skeptic would say, okay, does this apply to other illnesses?
Right.
Do the last hours or days of life look the same in cancer or heart failure or dementia? And I'm not aware of any head-to-head studies comparing such things. And I know they're starting to get a few more studies out there. I think there might be one in heart failure. But it would seem to me that this follows the same sort of general principle that we see in like dementia, for example. And what I mean by that is early on in dementia, all these different subtypes have different presentations and they look different, but they converge over time, and they all sort of converge into the same appearance in those last weeks of life. And I suspect that dying does the same thing, that it doesn't matter what you are dying from. Yes, initially in those years, months, things may present different, may look different, but they all seem to sort of converge in the same way. I don't work in hospice, so I don't get to see it every day. I don't know if those of the team that are in hospice get to see unique patterns that maybe they have noticed that isn't actually published or not, but I don't know. That's my 2 cents of what I struggle with when I think about these things, just trying to be evidence-based.
Yeah. And most of the data did come from MD Anderson from Dr. Lee, I believe.
Yeah, that is true.
Hey, Marty, this is Leanne Lau.
Hey.
Jen, great talk.
Thank you.
I think, Marty, I think your point was kind of interesting here. And I guess the only exception I'm coming to mind with right away is really acute death. You know, that would maybe be the distinction where the pathway is potentially different. Somebody who dies from, you know, a sudden stroke or hemorrhage or something like that. I guess my trauma experience here is coming in that the deaths I saw in those situations are significantly different from what I see now. So that was my only thought to your point. But Jen, just as a question, I guess as you were talking sort of about some of the, you know, hearing questions and those unresolved issues that probably we may never get excellent resolution to, my thought would be, do you have thoughts about how you talk to patients about that in terms of, you know, the lack of evidence, but still getting that sometimes there's value to patients' families to have answers to that. So I guess I was just curious about your thoughts in that regard.
For me, I try to say that it could be helpful for them, but I think it's really helpful for the families to remember their loved ones in those last times and share the memories that they have, the happy ones, obviously, not reliving the past traumas. I typically state there's not a lot of great evidence, but there are some that out there that do believe that it could be one of the last to go, and that everybody is a unique individual. And so if they feel like it would be helpful for them, that not every that it could be it's their decision, I guess.
Hi, Jen. This is Steve Brommelfinger. Good talk. Thank you for sharing this. What strikes me about what you presented isn't so much, I don't know. I mean, Marty asked what it's like for those of us who work more in a hospice setting. I think that's sort of an artificial setting, somewhat, in the one where we care for the dying, because we have such highly trained staff and in a unique setting. I do feel like the physical exam that the physician or APC would perform is helpful for, but I think I do think there's tremendous value to the family just seeing the touch and the care related to that, but that's also emphasized in multiple ways by the nurses and other hospice team members there. I guess, Jen, I'm curious your thoughts about how you, I've noticed in the hospital setting when patients die, especially lately, it seems like there are a lot of new nurses. You talked about the interns. People have never seen a person die before. And how do you promote this sort of skill set and observations just to kind of normalize the dying process for the healthcare team?
It's a great question. One that, to be honest, I don't think that I've had that thought about directly. I'm thinking about the nurses side. I know that when I've had cases where it has been a traumatic dying process, I do tend to stick around and ask the teams like how they're doing, how I can support them best. And I think that's important too. And just advocating more for really early involvement of palliative care, I guess, in those situations.
So I'm Eve. I'm a nurse practitioner in hospice specifically. And first of all, fantastic presentation. I really like the quote at the end about, the importance of love and presence as much as everything else. One of my roles here in Illinois is I help manage the GIP hospice patients, and I am in awe consistently with it. We have very skilled clinicians, patients actively dying, coming on actively dying, and that component of existential pain, unresolved issues. It's amazing how long somebody can be actively dying with that component going on. It's often, what we'll dig into a little deeper. We have skilled clinicians with that, the physical presentation, and we're in this world, right, of hey, throughput with these patients and getting them, to the proper level of care. And it's something our team is getting better at, is really, digging into why some of these people that they look like they can die for, 7-8 days and be active with all these signs that you so well presented here, Jen. So I know, the question and the awe that comes with this type of work. But thank you for this presentation. Fantastic.
Thank you.
So what I had shared in the comments, I'm on 2 meetings, so I apologize. What I shared in the comments is one of the ways that I like to explore existential questions is asking the question, what does death look like for you when the patient is able to answer it? And I'm always fascinated how much a patient is able to give insight into their own experience of their body. We've had a number of patients at Zilber that have said, I think it's going to be in the next 24 hours. And more often than not, I found them to be right. And I'm wondering what kind of research or experiences you all have had, or Jen, you have had around a person's awareness of their body.
I don't know that I've had enough experience or had the insight to ask that question. I think I will probably do that in the future. And if there are no, it's something that I would definitely be interested in looking into and trying to do a study on. That's a great one. Thanks, Jake.
I see the same thing, Jacob, here in the hospital, though we get them a little bit more upstream. When I ask people what it is that they've heard about prognosis, if the answer is they haven't yet had that conversation, I'll ask them, well, what do you think in your gut? What is it telling you? What do you feel like your body is? And boy, more often than not, they're pretty close to what it is that I'm guessing. So there's something to that, though I'm not aware of any actual evidence base that proves or disproves any of that. So, All right, we are just about at time. So Jen, we appreciate you being here with us. Thank you for the wonderful presentation, and we hope you all have a wonderful Friday and weekend.
Sure.
Bye, everybody.